สวัสดีท่านแขกผู้มีเกียรติทุกท่านนะคะและก็ท่านวิทยากรชาวไทยและชาวต่างชาติค่ะยินดีต้อนรับทุกท่านนะคะเข้าสู่การประชุมช่วงบ่ายในวันนี้นะคะและเพื่อไม่ให้เป็นการเสียเวลานะคะในลำดับต่อไปจะเป็นการเสวนาในหัวข้อความกลมกลืนในระบบหลักประกันสุขภาพภาครัฐประสบการณ์จากนานาชาติและอนาคตของประเทศไทยโดยมีท่านวิทยากรไทยและต่างประเทศประกอบด้วยศาสตราจารย์เกียรติคุณนาโอคิอิเคกามิจากมหาวิทยาลัยเคอิโอประเทศญี่ปุ่นศาสตราจารย์ไหฟังจาก China Center for Health Development Studies มหาวิทยาลัยปักกิ่งประเทศจีนและศาสตราจารย์ดร.อัมมาสยามวาลาจากสถาบันวิจัยเพื่อการพัฒนาประเทศไทยหรือ TDRI การเสวนาในช่วงนี้นะคะได้รับเกียรติจากคุณพิมพาวดีพหลโยธินรองผู้อำนวยการสำนักงานภูมิภาคเอเชียมูลนิธิ Rockefeller เป็นผู้ดำเนินการเสวนาค่ะดิฉันขอเรียนเชิญท่านวิทยากรและผู้ดำเนินการเสวนาบนเวทีค่ะ May I invite all afternoon plenary speakers and moderator on the stage.
So good afternoon, ladies and gentlemen. I hope that you've had a very good lunch and full of energy to begin this very exciting plenary session, which I believe will be very enriching because we will be sharing cross-regional and cross-country perspective. So just to get us settled, maybe let me just list out to you the objectives of this plenary session. So the first objective is actually just to hear from our distinguished guests here from China, Japan, and of course from Thailand on the relevant reform processes and the experiences from the two countries plus Thailand. Then to understand the differences among the three schemes in Thailand and the progress of harmonization that is currently occurring. Just to set the tone, I think the uniqueness of this session is first of all different from, I guess, from what you've heard in the morning in the parallel sessions is that these three countries are very diverse. So the richness will come from the diversity of the health systems. And also, I think we should not forget that historically and politically, they're also very different systems. So for example, Japan is a single payment with thousands of funds. It's also a small geographical, in surface area, a small geographical country, but it has a huge population relative to its size. It's also facing a challenge of aging population. So this is context is specific to Japan. When I conjure China, I think of the barefoot doctors, then quickly the economic reform and all the changes that have come about after Deng's overture to a new economic system. And China is, as you all know, it's a large country. It's many, many times bigger than Japan and Thailand. It has 1 billion people. So the challenges to China are also unique and rich. Now, Thailand. 12 years ago, we achieved universal health coverage. And Thailand has its own unique footprint in how it has achieved the current health outcomes. And as we all know, Thailand is a constitutional monarchy, interceded with military coups. I think we've had a total of 19 constitutions and maybe 20 successful coups. I'm not counting the failed ones. So I think we're all quite unique. And I think within this richness, there's a lot to be learned. Okay. So let's just try to keep these factors in mind as we listen to the presentations from our three colleagues. So now let me introduce you to the panelists again. First panelist I'd like you to introduce to you is Professor Naoki Ikegami. I don't think he needs much introduction, but I'll do the formality anyway. He was the chair of the Department of Health Policy and Management at the Keio University School of Medicine, and he's widely recognized as Japan's top health economist. My second colleague here is Professor Haifang. Did I pronounce your name correctly? Okay. He's a professor of health economics at China Center for Health Development Studies, Peking University. Professor Fang taught at the University of California, the University of Miami, and then later the University of Colorado, all in the United States. And his research interests include health systems and health disparity. Now I turn to our third colleague, Dr. Amar Siamwala. Again, needless to say, I don't think he needs further introduction. But for those of you who might not be familiar, he's probably the most prominent economist in Thailand. And if you don't know, I think he was instrumental in developing the neoclassical school of thought here in Thailand. And currently, he serves as the chairman of the board of Thailand's Development Research Institute. So maybe one round of applause for our distinguished guests. Thank you. So why don't we just go ahead, and I would like to invite Professor Ikegami to present.
Good afternoon. I'm greatly honored to be invited to give my presentation. So without much ado, I'll go along with this. Why there are over 3,000 plans in Japan? Social health insurance was developed very incrementally. Employment-based health insurance, we have 1,500 plans. Companies such as Toyota and Sony or associations gradually establish their own plans. And then we have the residence-based health insurance, 1,800. And each municipality gradually established its own plan. And each plan, the principle is that premium revenue equals healthcare expenditures. But the ability to pay premiums differs by income level. Expenditures differ by age composition and access to care. The government has tried to mitigate this, but every plan has a different rate. That is the percentage of income levied as premiums. Therefore, merging will increase the rate of some plans. So therefore, plans would agree to a decrease in premium contribution rates, but they will never agree to an increase in premium contribution rates. So therefore, we have had no mergers. Now, Japan's system is different from Thai in four aspects from this flow chart. The green shows the flow of money from taxes. The red shows the money from premiums. The first tier, the one on your left side, is similar to your civil servants and social security organization, the formerly employed. Now, they have relatively high incomes, so the contributions from the employer and employee are sufficient to pay for all their healthcare costs. And we have about 1,500 of these plans. The second pillar, this you don't have in Thailand. This is for the small companies, small being less than 700 employees. The national government is the insurer for this. And since the small enterprises pay their employees less than large employees, the government subsidizes 16% of their costs. The fourth is similar to your UC, and there the government pays half of their costs by taxes. It actually ranges from about 1/3 to more than 70% according to the income level of that municipality. But the big difference between Thailand is that even in these schemes, half is paid by premiums. The fourth difference is that in the fourth tier on the right-hand side, this is for the 75 and over. And they used to be part of the third pillar, but since they cost so much, this was made an independent insurance, and the 47 prefectures that would be similar to your provinces it is organized on the province level. And the government pays 50%, but the interesting fact is that 40% all the other plans must contribute to the care of the elderly. So as an employee, I paid about $400. Of that $400, more than $150 and close to $200 went to pay for the elderly 75 and over all over Japan. The big difference, the fifth big difference is that in Japan we have over 3,000 plans, and also our providers are private sector dominated. But the one thing that ties these together is a single pipe. It's fee for service, but with a fee schedule that defines both the benefits, what people get, and also sets the price and conditions of bidding while staying within a global budget. The last difference between Thailand and Japan, which is not mentioned here, is that preventive services are not part of the fee schedule. That is left to each of the 3,000 plans to design their own prevention services. Now, how benefits were harmonized. In 1927, the original fee schedule was designed for government-managed insurance plan. That is the second pillar, covering small enterprises. In 1943, all employment health insurance plans adopted this fee schedule. In 1959, all residence-based, that is for the informal sector, adopt this fee schedule. By doing so, there was equity because service benefits became the same for all plans. Access expands as provider accept all patients because they pay the same amount regardless of the scheme. There's also cost containment, global cap on all expenditures, which I will explain later. So what does the fee schedule determine? Virtually all patients' benefit package and co-insurance amount for all social health insurance plans. More than 95% of out-of-pocket expenditure is to pay the co-insurance. That is normally about 30% to 10% for elders for services and drugs listed in the fee schedule. Extra billing, that is billing for services outside the fee schedule, is restricted to extra room charges and new technology being evaluated for its efficacy and safety. Once approved, that is to say, once the efficacy and safety has been approved, then it automatically becomes listed in the fee schedule. Balance billing, that is asking patients to pay extra, is strictly prohibited. For the health facilities, it sets the fees and conditions of billing, regulates over 95% of all revenues of all providers by setting fees and controls quality and volume of each item. For example, conditions for billing rehab therapy, the facility must employ 5 or more physiotherapists, meet minimum physical requirements such as a therapy room more than 160 square meters, and also the patients must be within 150 days of onset. Adherence to these conditions is monitored through claims review and on-site audits. Now, this is revised every 2 years, and there's 3 steps to this revision. And the first step is setting the macro revision rate. Now, this is set according to this formula. Next year's expenditure will be equal to last year's expenditures plus the macro revision rate, which can be negative or positive. That is, it can be decreased or increased. And increase is due to non-price factor, which I will call alpha. Alpha is shifts to more expensive services due to advances in technology, from CT to MRI, for example. Although the price remains the same for CT and MRI, if the doctor orders more MRI than CT, then expenditures would increase. There are also increases in volume due to aging because aged elderly use more resources. And this is based on the rate of increase for the past 3 years, which is about 2 or 3% per year. Now, this is historically given so that by setting the macro revision rate, a global budget is imposed. For example, if the past 3 years was 2% per year, then if the macro revision rate was set at minus 4%, you have a budget neutral health expenditure. The second step is setting the micro revision rates for each item. Now, you can envision a huge Excel sheet and where the price of each item is adjusted either up or down and volume of each item. And based on this adjustment must equal the global budget as set by the macro revision rate. The third step is revising the conditions of bidding, and this regulates the volume and quality of each item. And as you see, this is a huge book. I was asked to translate this, but this is an impossible task. It's as thick as a dictionary, encyclopedia, because every item is strict, is very precisely defined, as also the conditions of bidding. You can see how health expenditure has been contained. This is the item by item decreases. The MRI scan. If you look at the blue, you see that volume has continued to increase, but expenditure decreased in 2002 following the fees decreased 30% to the MRI. The reason why it decreased 30% was twofold. Firstly, minus 2% was a global revision rate cap. So to stay within that global budget, certain procedures, such as MRIs, which have become cheaper because the equipment could be bought cheaper, were decreased by 30%. By doing so, the cost curve was bent. It can be also new items can be added. There's fees to encourage physicians to refer. Originally, it was for clinic physicians, primary care physicians to refer, and for hospital physicians to refer back. Now has been expanded to long-term care providers. So they are paid $20 to write a referral form. And the conditions of payment says it must include specified information about patient, so that just writing a referral would not be sufficient. There's also fees to encourage physicians to provide end-of-life care in the community. The fee for a visit made on the day of death is paid very high at $250 to $500 US. And the amount depends on the facility standards. The conditions are that the physician must have made 2 visits within the past 14 days, so that they won't get paid just to make a visit on the day of death. And third step is conditions of payment or revisions. This is the very hot topic in Japan about nurse staffing levels. The bed and board fees are determined mainly by the hospital's nurse staffing level. Higher fees to encourage hospitals to staff at higher levels. Because higher nursing staffing levels are being regarded as the primary means to achieve quality in inpatient care. But to build the highest nursing level fee, the hospital must meet the following. First, the night duties for every nurse must be less than 72 hours per month, and 15% of the patients must meet the defined acuity level. When the government announced this, many hospitals rushed to hire more nurses so that they can bill at the higher rate. So since too many hospitals bill this highest level, in the 2016 revision next year, the acuity level criteria will be made stricter. So that by fine-tuning the conditions of payment, the provider's behavior will be influenced. I should mention that inpatient care is based basically on a DRG type of payment, but this nurse staffing level as a bonus payment to the basic DRG rate. So the higher the nursing level is, the added payment on top of the DRG payment. Now, who decides? The official process, the first step is setting the macro revision rate. They are about to do so within a month from now, because the budget must be set. The new budget year starts in April, and so therefore the budget for health expenditure must be set within this year by the middle of December. The Minister of Finance and Health and top bureaucrats try to come to agreement. Politicians try to intercede, but ultimately the Prime Minister makes a cabinet decision. And this has very much a symbolic impact, because if it was positive, it means that the government is pro-health. If it's negative, it means pro-austerity. As one vivid example, in the 2012 revision rate, it was plus 0.004%. This is not a typo error. It was actually this amount, because the government wanted to keep true to his manifesto that it will increase health expenditure. The second and third steps are then item-by-item revisions and conditions of payment. This decision is made by the Minister of Health following reports from the Central Social Medical Insurance Council. The council members are 7 from payers, insurance plans, industry, labor unions, 7 from providers, physicians, dentists, and pharmacists, and 6 from public interest, usually academia, and 10 from interest groups, such as the Nurse Association and Pharmaceutical Association. You see a council meeting in progress. It's conducted in public, and so all decisions must be made in this public meeting. But anyone who has any experience in policymaking will know that no real negotiation can be done within this large group. So who actually decides? It is a key role of the ministry's Health Insurance Bureau. It is responsible on one hand, it is responsible for the viability of all social health insurance plans. Social health insurance plans must not become bankrupt. So this means how much subsidies to plans except for those in the first tier that is not subsidized by taxes. How much transfer payments to pay for the costs of elderly. The above must be calculated, negotiated, and revised. And no one wants to pay more. It is also responsible for the viability of virtually all providers. Bankruptcies must be minimized to maintain service delivery. It is also responsible for maintaining databases to calculate the financial impact of making policy decisions. Within the Health Insurance Bureau, there's the Medical Service Division. This is responsible for managing the fee schedule as Secretariat of the Central Social Medical Insurance Council. It negotiates with providers on revisions, both on the increase and decrease rate and also on the conditions of billing. It is also issue ad hoc directives on the conditions of payment. There's 21 deputy director class. The physician posts are the director and 5 deputy directors, plus 8 other positions. Dentists, nurses, and pharmacists as deputy directors in their respective sections. So in conclusion, our experience is that merging health plans is difficult, in fact impossible, because premium contribution rates differ according to the enrollee's income, risk profile, age, etc., and access to providers. And the key aspect is how accessible to tertiary hospitals, because if the patient has pneumonia and goes to a tertiary hospital, the costs are going to be much higher than going to the district hospital. And enrollees will oppose increases in premium contribution, especially if they do not lead to any tangible improvement of their benefits. They are quite prepared to pay more if their benefits expand or the enrollee's age, but not to pay for the expenditures of any other plan enrollee. But on the other hand, unifying the fee schedule has led to equity by making the service benefits the same for all patients. Integration of public and private sectors providers by paying them the same amount for the same service. And cost containment by setting a global budget for all social health insurance expenditures. I think the bottom line is that it has successfully managed expectations about healthcare. For the people and patients, extent of benefits, how much they must pay as co-insurance. For physicians and hospitals, how much they expect to earn. We have not heard about how much Thai physicians earn relative to nurses or to the general population. In Japan, in the public sector hospitals, the doctors earn about 2.5 to 3 times that of nurses, and nurses earn about the same as the average worker. And they have come to accept this as a norm, and that in health expenditures, half of health expenditure is manpower costs. So how much you're going to be prepared to pay your providers and how much doctors and nurses expect to earn from giving the service are key to deciding how much expenditures you are going to invest in healthcare. Thank you very much for your attention.
Thank you very much, Professor Ikegami. I think we've drew some interesting lessons for the Thailand harmonization process. I think the things that stood out for me are, number one is the importance of actually managing expectations. I think that's one of the key components in a successful harmonization process. Another salient characteristic I think is quite, that really stood out for me is the very well-defined and actually strong mechanisms for dialogue that Dr. Kigegami has explained. If I had to sum up the Japanese health insurance system in one sentence, I would say that with a single payment a fee schedule and 1,000 funds, I would say that Japan is a case of unity within a lot of diversity. So how did Japan achieve this unity among all the 1,000, no, maybe 3,000, I guess, health schemes? So that's something maybe can be thought about further for Thailand. Now I would like to invite Professor Haifang to present for the case of China's reforms.
Good afternoon. It is my great honor to attend the first national conference on Thai universal health coverage, and thank you very much for your invitation. Today's presentation is about harmonization of health insurance schemes in China, and we have some plans, and we are working on these type of harmonization now, but we have some issues, and I want to share those kind of issues in some of the pilot experience. So here is the outline for today's presentation. At the very beginning, I would like to share some background information about China and also the China's health insurance system. And after that, I want to show some of the pilot experience of harmonizing China's various health insurance schemes or system. And then what are the major issues we are facing, and then what are the future directions we may have. Brief information about China. In 2014, we have 1.37 billion people. Like that is very large population in China. And then the GDP in 2014 is more than 10 trillion. So China is the second largest country in the world with more than $10 trillion as a GDP. And then the GDP per capita in 2014 is about $7,575 the US dollar. So China now is almost like a middle income country. And then the health expenditure in 2014 is about 573 billion US dollar, almost like a 5.55% of the GDP, similar to Thailand. And health expenditure per capita in 2014 is now very high. It's only 419 US dollar. And for those kind of 419 US dollar, 30% is from the government, so government subsidies. And 38% is from the social health expenditures, mainly from the social health insurance and also the private health insurance. And then 32% is from individual out-of-pocket. So the individual out-of-pocket is still pretty high in China. In China, we almost like a social health insurance system, mainly sponsored by the governments and the various governments, from the central government to the provincial and the local governments. And commercial health insurance market share is about only 10% in 2014. So 90% of the funding are from the social health insurance funding. And commercial health insurance, sometimes we call private health insurance, works as a complementary to the social health insurance for some co-payment or some deductible payment. And social health insurance cover more than 95% of the Chinese population in 2014. So for the last maybe 2 or 3 years, basically we also achieve universal health coverage, but it's only for the health insurance coverage instead of for other 2 dimensions I will discuss later. There are basically 3 types of health insurance schemes in China. The first one is launched in 1998, called Urban Employee-Based Basic Health Insurance Schemes. That is only for the employed population in the urban area. In 2014, about 283 million Chinese people, they were covered by the urban employee-based basic health insurance. For those kind of employee-based basic health insurance, the spouses and their family members are not included, so only the working people. The Euro New Cooperative Medical Scheme was launched in 2003 and only for the Euro population, and it covers about 736 million in 2014. The last part for the urban resident, so it's called urban resident basic health insurance schemes. That is for the non-employed population in the urban area. For example, for those kind of school children, for the infants, and also for those kind of self-employed people, they were covered by the URBMI. And in 2014, about 314 million people were covered by the urban resident basic health insurance. So how can we finance the three types of health insurance? Let me see. Okay. For the employee-based basic health insurance, the payroll taxes are the main fund source. Government normally don't provide any funding for these type of health insurance. And the employer and the employee have to contribute based on their total compensation or by the salary or the wages. For the other two type of health insurance, for the cooperative medical scheme, for the rural population, and also for those kinds of non-employed population in the urban area, the government subsidies are the major revenue source. 80% of the funding is from the various government, from the central government or the local government. The per capita fund for the employee-based health insurance is about 7 times higher than that for the urban resident basic health insurance and also for the cooperative medical scheme. So in other words, there are very, very inequality for the fundings for three type of health insurance schemes. The three health insurance schemes are separately administered and operated at the national and also the local levels, provincial and county levels. For example, for the new cooperative medical scheme for the rural people, is administered by the National Health and Family Planning Commission, formerly the Ministry of Health. And for the urban resident basic medical insurance and also for the urban employee basic medical insurance are administered by the Ministry of Human Resources and the Social Security. So in other words, you have different administration for different health insurance schemes. It is very, very difficult to consolidate them together. How about health risk pooling? Even though we have three health insurance schemes, we call three health insurance schemes, they are very, very diverse. For example, for the new cooperative medical scheme in the rural area is pooled at the county level. In China, in 2012, we have 2,852 rural counties. So basically, we have more than 2,800 new CMS plans. For the urban resident basic health insurance and urban employee basic health insurance, they are pooled at the municipal or prefectural levels. So there are more than 300 municipals or prefectures in 2014. So in China, we also have more than 3,000 health insurance schemes, even though they call the same name. But we almost, in Japan, we have 3,000. But in China, we also have 3,000 based on the risk pooling and based on the financial responsibilities. How about the benefits? Even though we call the universal health coverage, it is only for the insurance coverage. The benefit packages and financial protections are not equalized within all or and across the schemes, so which is critical barrier for achieving the full universal health coverage. So in other words, even though you call the same health insurance, like say, new cooperative medical scheme, in different province or within the same province by different county, you are going to have exactly different benefits and different financial protection. And the rural population have more restricted access to healthcare than urban residents and carry a higher financial burden. That is because most of the good hospitals and the physicians, they were in the urban area. And then for the rural people, they have to be out of network to go to the urban area to see a doctor with a very high quality or use the better hospitals. And then they have to pay a higher co-payment because that is maybe out of network. Second, right, there will be a lot of costs for them to do the transportations and also for the hotels and others. The disparities among health insurance schemes, like say accessibility for 245 million migrants is also affected by the fragmentation of health insurance schemes because you have your own health insurance in your county. If you go to other county or other province and work there, you cannot use the health insurance in other place if it is like a houseman, like it is like a gatekeeper. Within the rural regions, the new CMS, the new cooperative medical scheme, offers a much higher benefit package in rich rural counties than those in the poor counties as a result of the gaps in economic development. So we just recently published one paper led by the Professor Meng Qingyue from Peking University in the Lancet. We just want to say consolidating the social health insurance benefits in China is very important. That is the pathway towards an equitable and efficient health insurance. So if you are interested, and it is very good for you to download this paper and read this paper. But for the harmonization of health insurance schemes, we think, right, to establish consolidated health insurance schemes by 2020 is one of the main goals in China's current health system reform agenda. So that is by the government commitment. And achievements of the full universal health coverage needs both a vertical consolidation, right? Say new CMS approved from the county levels and urban resident health insurance and urban employee-based health insurance from the municipal levels to even higher levels, say provincial levels, because China is a very, very huge country. So it is very, very difficult to have one universal health coverage for entire China for different places. So if you can have universal health coverage in the provincial levels, that will be much better than the current situation. And also the harmonization or the horizontal consolidation, like merging the fund pooling of the three schemes, because there will be much better to have the same financial protections and also the benefit from different health insurance schemes. And some pilot consolidations or the harmonization have been done in selected area, and we want to share some of the pilot information. By the middle of 2014, 7 provinces, including Chongqing, Guangdong, Ningxia, Shandong, Qinghai, Zhejiang, and Tianjin, were in the process of consolidating their social health insurance schemes. China has 31 provinces, so about 1/4 of the provinces they are in processing of consolidation or harmonization. And those kind of province or provincial levels area, basically they are more developed or they are big, but with very, very few population. So that will be much easier for them to do something if you have more resources or the population is small. The practice of consolidating the schemes were also found in some municipal cities outside of the provinces we talk about. Consolidating of the schemes is usually initiated between the new CMS or the new cooperative medical scheme for the rural population and also for the urban resident basic medical insurance because of their similarities in funding sources and the levels, because most of the funding for these two health insurance are from the government, 80% of the funding from the government, and then the protection levels, financial benefits are almost the same. So at the very beginning, it is relatively easier to merge these two health insurance plans together. And merging the new CMS and the urban resident basic medical insurance administrative offices and the staff, and creating uniformity of information system, and integrating funding collections and the pooling, and unifying benefit packages and provider payment system are the major elements in the consolidation or the harmonization. I want to give you one specific example. That is example from the Dongying city or municipal city in Shandong province. And Dongying is pretty developed area in Shandong province. So Dongying is a municipal city consisting of 3 rural cities and 2 urban districts in Shandong province. So from November 2012, the municipal government just started consolidating the new CMS and the urban resident basic health insurance in 2 phases. The first phase is they try to consolidate the administrative resources, and the second phase is consolidating the financial and the benefit packages. And then, so in the first phase, in Dongying, the new CMS administrative offices was transferred from Dongying Department of Health to the Department of Human Resources and Social Security. And then the new CMS for the farmers, for the rural population, managed offices and urban resident basic medical insurance management offices were merged together. And some of the employee or the staff for the new CMS for the rural area joined the management offices, the new management offices, and others were relocated to other sectors to reduce the human resource cost. And then the information system were merged finally. And then in the second phase, the fund pooling and the management of the new CMS were moved up from the county level to the municipal levels, integrating with the urban resident basic medical insurance. And integrated funding collection system were applied to all the counties and the districts in Dongying. And the rural and the urban residents were covered by the same benefits packages, including the reimbursement policies and health services. And then the rural residents receive a better package equivalent to that of urban residents. Right? For example, the drug list in the new CMS for the rural people were extended from 523 at the village clinics and 785 at the township health centers to more than 2,387. So almost like the same as the urban resident basic health insurance. And then the integration of new CMS and the urban resident basic health insurance saved the government subsidy about $4.4 million in 2013 as a result of the reduced overlapping enrollment of the new CMS and the urban resident basic health insurance. And how about consolidating about all 3 schemes? Some of the area, not in Dongying or in some of the area we just talk about, some of the very, very pilot area also try to consolidate the all 3 together in various forms, including the simplified procedure for the transfer of the insurance types and the free selection of different benefit packages under a consolidated health insurance schemes. However, to our best knowledge, some selected area try to merge 3 schemes in terms of their administrative organizations, but they have not really merged the fund pooling with universal benefit packages. So in other words, because the urban employee-based basic health insurance, the funding is much, much higher than other 2. So it is very, very difficult to merge them together. What is the major challenges in China for the consolidation or the harmonization? The first one is a lack of institutional design and the guidelines from the national government constitutes one of the most critical constraints. Now, there are still a lot of debates in China and the discussions, but we don't have a specific plan yet. Second, operations of the consolidated schemes requires a higher capacities in administration and the information system, and this requisite is not sufficiently met at the current situation. The last one is the funding sources are still limited, particularly for the new CMS and also for the urban resident health insurance, because 80% of the funding now are from the government, from the central government, also from the local government, and the government do not have enough money to put more funding and then to have the same funding resources or funding levels as the employee-based health insurance. That is almost impossible. So what is the keys for consolidating insurance schemes in China? We believe that first, there should be different dimensions of the fund levels. Now, for those kind of employee-based health insurance, it is fairly easy. You just charge or ask them to contribute based on their salary or wages, right, or maybe the payroll. But for other like informal sectors and also like a self-employed population, also for the farming population in the rural area, so it will be very difficult to ask them to make a contribution to the health funding. Second, what are the standards of the service provisions? Because now in the urban area and in the rural area, the standards of the service provisions are very, very different. And the cost sharing methods are very, very different in the urban area and also in the rural area, with much, much higher co-payment from the new CMS and also from the urban resident basic health insurance. And finally, the payment mechanism is still fee-for-service for the majority, even though we try DRGs and also try capitation and the global budget. But the major or the dominant payment system in China is still, or mechanism still fee-for-service. So what shall we do in the future, right? We will talk about all these four maybe for our campaign. So I want to talk about these four specifically. The first one is we would like to develop a national guideline and action plan, like Thailand want to do the same thing, I think. We want to develop a long-term plan for national universal health coverage schemes. And we try to say a risk pool of the new CMS can be raised from the county levels to a much larger risk pool at the municipal or even the provincial levels. And then the consolidation of the new CMS and the urban resident basic medical insurance are more feasible than consolidation of all three together at the very beginning. So how about just merge these two at the very beginning? And then we also want to encourage innovative consolidation pilots. Before a national or provincial universal health coverage or insurance scheme is achieved, a risk adjustment mechanism could be established at the provincial and the national levels based on economics and population characteristics to redistribute risk. Now, there are no any of these type of redistributions. Another possible way is to use a family-based mechanism to consolidate the urban resident basic medical insurance and the urban employee basic medical insurance, in which the fund from these two can be put together. Because like the employee-based health insurance in the United States, you can not only can cover the working population, you can also cover the family members, the spouse, and the children. We would like to strengthen the political leadership and the financial support. A national guideline for the importance and the approaches of a scheme consolidation is extremely needed, but we don't have the plan now. And the consolidation of the schemes must be a part of the government's social development agenda as a critical strategy for a justice society. And the level of consolidation and responsibility of different levels of governments are important issues we have to deal with. And then we need to build capacities of the scheme's administration. Now, the administration is at the county levels, but if you move the administration to provincial levels or even like a city levels or provincial levels, the current national authorities in charge of the three schemes have their own advantages, as we mentioned. Yeah, like Social Security authorities have rich experience in administrating the urban social insurance programs, while the health authorities have a better understanding of the healthcare practice and a richer experience in administrating health providers. But in the long run, and we believe that an independent authority could be created to specifically administrate the insurance schemes, because I don't think, or we don't think, or may not be very good to ask one of the, like a Social Security or the health authority to do those kind of work. We may want to have a new built organizations. And thank you very much for your listening.
Thank you very much, Professor Hai Fang. While we wait for Dr. Amar to return, why don't I just take this opportunity to maybe ask both of you maybe a question on equity, since I think the objective of the reforms is equity. Oh, Professor Amar is back. He's very fast. All right, so let me go on with the agenda, and maybe we can pose the question of equity later during our Q&A. You were very quick. No, not at all. So this will be more of a dialogue between Professor Amar and the audience, facilitated by me, so there will be no PowerPoint. I will just start, given time. So after a little bit more than a decade of achieving UHC in Thailand, what I think it's important to understand, what is the main motivation for the harmonization? And when I think about harmonizing the three schemes, it conjures a really big feat. So as a public opinion influencer, I think it would be great to hear from you, really, what are the deep drivers that are pushing ahead this quote-unquote movement?
I think the main reason for the harmonization is that these three schemes that we have came to Thailand at different times, when the state of medical knowledge and correspondingly medical expenses were quite different. The civil service scheme came in at a time when medical expenses in general were much lower than later. And it's given as a kind of welfare for the government employees in lieu of a salary increase. But the total medical expense at the time, even for ordinary people as a share of income, was probably smaller. So the government felt it could afford to give the civil service benefit scheme and pay for, which was not only generous in terms of the money spent, but in terms of coverage of people. It includes not only the family, the children and wife of the civil servants, it includes the parents of the civil servants, and it extends into their retirement. So it's super generous. The government felt it could afford it. The Social Security came in later, but already there is an element of a limited budget, limited taxation. The civil service scheme, for a long time, until about 6 years ago, has absolutely no budget constraint. And I kid you not, it does not have any budget constraint. Everybody was very happy among the providers. They can spend to their heart's content. They can always draw on. And because the administrator of the Civil Service Benefit Scheme is the Comptroller General's Department. They can, it's just, they have an open door to the safe, to the government vault, and can withdraw as much as they want. And all through the system down to the individual doctors know that there is no budget constraint. So, I mean, the money was, that was why the total cost of civil service benefit scheme went sky high. And that's a problem now. It's a most difficult problem to tackle, because actually if you look at what kind of benefits, what diseases or illnesses it covers, is not very different from UC. But civil servants can walk from one hospital to another hospital and run up a charge, and they have free choice of all government hospitals. The only restriction is at no private hospital, thank God. But that was, and that's why, as I said, it went sky high. But when the Social Security Office introduced a Social Security, it was a much better scheme in that sense. There was a limitation through capitation process of the amount spent. So again, what illnesses is covered and not covered, they're not that different. Maybe certainly not different now. In the beginning, there were probably much more restrictions. But when the UC came in, we had the experience of a limited, constrained budget system, and we applied that. It turns out that Dr. Sangwon, who was very instrumental in bringing in, was helping the Social Security Office at the beginning of his career, and introduce his capitation scheme. So he had experience of capitation. So we have to now harmonize. We have to harmonize many things, but one of the things we have to harmonize is the system of a limited or constrained expenditure. We have, in the case of civil servants, and now with everybody, we have introduced it as far as inpatients are concerned. Okay, but even then, there is still some issue on that. But that's the first inkling of a harmonization. At least the concept of DRG is now common to all three. And hopefully, by the end of this year, the system of the clearing of DRG claims will now be also harmonized and indeed, hopefully, centralized. So that's one very little step forward already before this big thing.
Maybe just to fully answer this question, would you like to say maybe link it up maybe to the current legislation process that is being deliberated in terms of unifying the three schemes and the various governance mechanisms that you see could be necessary for the reform to move forward?
I'll approach this through the idea of governance. The three schemes have developed independently. They have institutions, organizations, and constituencies of their own. And it's very difficult to bind them together through a hierarchical governance structure that will, somebody talk about a super board which overrides the individual boards. I don't think that's a feasible process. That has to be seen. We are still in the first stages of designing a legislation. But my proposal is for a very modest negotiating center, something like the picture that Dr. Inigami showed us, of a room full of people talking, but with no impact until, talking basically to the galleries instead of to one another. What we are hoping is to have that kind of talking, but also supplemented with the real bargaining that has to be done. And we have a few models of that. But in the end, given the vast disparities between the three schemes and very, very strong constituencies that each have, okay, it's very difficult to steal from somebody. Everybody considers, certainly the Social Security people, which has been well funded in the past and has accumulated a sizable reserve, just a medical fund. They certainly look at UC, the NHSO people, as trying to grab that fund. Same with the civil service. Only the people who are enthusiastic about harmonization is the NHSO. But I think the other two see that an orderly process of negotiated settlement is probably better than to be surprised one day when the NHSO grab a government and get the government to force a harmonization on them. So hopefully that's the scenario.
Thank you for that elucidation and reflection. Now, maybe linking to what you had mentioned about merging the three schemes and the challenges in dialogue and discussion, I think maybe to seek your opinion in terms of the equity dimension. When you mention grabbing resource away, usually when we talk about pursuing an equitable agenda, the first thing that people comes to mind is resource reallocation. And as economists, this is what we are probably talking about, is to reallocate resources in a more efficient way. And therefore, there will always be people who feel disadvantaged. So what is the equity dimensions you see that could bring people together or could also divide people? And I think within Thailand, it might be worth getting your opinion as a social influencer in terms of the understanding between equality versus equity and whether that also comes to play when we talk about harmonization within the health system.
First of all, you must remember that even today, medical expenses are a relatively small part of a person's budget on average. It can become a very large part in particular years, but it is a small part overall. So the equity part comes in this way, that when all is said and done, let me be brutally frank about it, a good universal healthcare system nationalize the purchasing power in healthcare for the benefit of all. We in the middle class pretend that we are benefiting from the ability to go out and buy our own health care. We can go and choose our doctors. We can do all that. But as we are finding out year by year, the hospital or the medical care expenses have been creeping up very rapidly. And why? Because there is an incomplete nationalization through UC. A large percentage of people's health expenditures, particularly clearly from the richer people, is spent on out-of-pocket expenses. Now, the problem with out-of-pocket expenses is that it's basically a fee-for-service system. And any fee-for-service system has been found out is it leads to a quick spiral of cost, particularly in Thailand, where there is no attempt whatsoever to control prices. No attempt whatsoever. The Ministry of Health is very remiss in terms of price control of drugs, of health services, and of doctors' fee, and so on. It considers, well, now we have UC. If people are hurt by high health care, they can go use the free medical services. But an incomplete nationalization of purchasing power in health is sometimes worse for everybody. This you can see in the US at the time when they include the Medicare in the late 1970s. It led to an immediate crisis of a cost spiral. When you include Medicare, there is an increase in demand for doctors' services, for healthcare services in general, and hospitals and doctors who provide these services find that their income has moved up because Medicare happened also to be fee-for-service at that time, even now, I believe. So you immediately inject increased purchasing power of the government. And because it's fee-for-service, for-profit hospitals have gained a lot in expense at the expense of cost-based hospitals, of charitable hospitals and other things, and state hospitals. I don't know what kind of hospitals exist but anyway, those that are not for profit. There is a large sector of that. And that incomplete nationalization led to the complete dysfunctional health insurance system in the US to this day. I do not know how much Obamacare has tackled that. Okay, but two things I found out when I came into medical care, study health economics. First, there is no perfect universal care system. You can't find one. It's a bit like Thailand searching for a perfect constitution. We write 19 constitutions and we haven't found a perfect one yet. Okay? That's the first thing I found. Two, there is a most imperfect health insurance system, and that's the United States. By any measure. And all you have to do is look at their history. That's another thing I found out. History matters a lot. Every country, the stage at which they have UC, the stage at which they have they enter into various reforms matter a lot. And in the case of Thailand, I am a bit disappointed that we're still far from a complete or near complete. No country has a complete nationalization of hospital care, but we have still a large sector of out-of-pocket medical care. And the worst thing that befall Thailand is something we are very proud of, which we should not be, and which we should be ashamed of, and that's medical hub business. That we are exporting our healthcare services when we do not have sufficiently elastic supply of medical care personnel. Okay, so.
Yes, so it's frightening that you pointed out the big elephant in the room, I guess, and I am aware that many big chains in Thailand are already listed on the stock exchange of Thailand, so I think that's definitely something that reflects the point of the danger of incomplete nationalization and the pitfalls that might lie ahead in terms of ignoring this big elephant in the room.
I don't care if the hospitals are for profit or not, as long as the purchasing of healthcare services is largely through the public sector. The provision can be any which way you want, but once the government purchases the bulk of the healthcare services, the government will then be able to regulate the system in a unified manner. We have a rather kind of very badly ununified. That's why homogenization is important.
Okay. So I presume financial sustainability would be one of the challenges going forward. So maybe now let's shift the debate a little bit and be a little bit more forward-thinking and anticipating the important challenges that might arise in light of this harmonization. And I think there are three major trends that are drivers that would create dynamism to this issue. One of them, of course, is Thailand is entering an aging society that will have direct impact on health resource distribution and utilization and financing. Another trend I see that is unstoppable is urbanization, as more and more people actually want to come to urban areas, and with new transportation systems, it will be easier to live in urban areas. And we all know that the health system in Thailand stops short in an urban area such as Bangkok, where care is more, where healthcare is more treatment rather than prevention or promotion. And then the third really big trend is, as what Professor Amar mentioned, is financial sustainability. So in light of these forward-looking trends, Professor Amar, could you maybe share your opinion in terms of how the harmonization process would have to take into account? Otherwise, there's no point harmonizing if you can't anticipate future issues.
That's something that we are very worried about. The main cost drivers in Thailand, first of all, and I owe the numbers on this, I owe to Dr. Thawan, who's sitting there and can start waving his hands if I get it wrong. The main cost drivers are aging, and for UC, it's about 2% per annum. And for CSMBS, it's, I think, higher at about 4%, thereabouts. But 2% is about the numbers we are talking about. It's not as high as I thought it would be. That's reasonably manageable. The second one is the unmanageable one, and that's the labor cost, personnel cost. We haven't been able to break it down into the wage component and the total employment component. This is employment in the healthcare sector. The two together combined is about 6%. Am I right? It's about 6%. That's the real kicker. It has been spiraling up, and in my view, the reason for the spiraling up is because we have this large unnationalized health expenditure side. I mean, you can see that with out-of-pocket expenses, which are mostly fee-for-service, not to mention the medical hub, demand for doctors have gone up. Doctors are able to command much better fees, and consequently, this 6% I'm talking about is in the public sector. But the public sector has been running behind, trying to catch up on the private sector. And that's what I really am worried about. The third part where I have an argument with Dr. Thawan, who is a medical doctor, is the cost of new technology. As an economist, I always say that technology should reduce prices. But doctors don't believe that. I have always wondered why. I can come up with two explanations. One is that much of the technology improvements are for older people like me. Okay, so we are dispensable. We don't need new technology. Let us drop dead. Okay, particularly if that technology is expensive without giving much more benefit of increased life years, quality adjusted life years. That's one possible argument. The other argument is that at the time of entry of new technology, costs are going to go up. Okay, at the time when this new system of treating cataracts, when these artificial lenses and so on came in, it was very expensive, but it has been falling and falling, just like computers, okay, or cell phones. So if Thailand is patient in adopting new technologies, doctors always like to have new toys, just like army people, just like soldiers. Now we have the two together running the country. Horrible thought. It's important that that we have to rather be careful about introducing new technologies. We have a very nice. The British have a nice, right, which kind of screens through all the new technologies and decide to adopt those that are cost effective. We have something like that. Hopefully, we are not going to have it have power. I'd rather they have had a lot of soft power and soft influence on NHSO particularly. We've been able to introduce new technologies or refrain from doing so for example, some vaccines, I think we stopped doing that because we found that pharmaceutical companies are overcharging. I think it's HPV is one, but there are a number of other things. I mean, all of these, the problem with medicines and healthcare services, if it saves life, how can you say no? Okay? But you have to sometimes really stand back and say, hey, is it worth it? We can wait for these new technologies for the price to come down. Then we can start saving life. But I understand that it's very hard to I remember I had to negotiate a lot in my stay, my last 10 years with the Budget Bureau. They are very mean-spirited. But there is a case of there is a new drug for treating leukemia in children. There are only 300 children who will be affected by this new treatment. The cost is somewhat high, a couple of million. And the Budget Bureau was hemming and hawing and said, should we do this and so on. So all I said is that you have 300 children's lives to consider. Absolute silence. I get my result. That's what doctors do, so be careful. Okay.
Thank you. So maybe on that note, mindful of time, so I would like maybe to ask one final question before we open it up for Q&A, because I think maybe some participants might be burning with questions to address the panel. Professor Amar, given your very illustrious experience in pushing forward, social development in Thailand, I wanted to ask you a maybe creative question. If you had a magic wand and you could make only 2 wishes with that wand to solve the issues in the health system related to harmonization, what would those issues be and why through your magic wand?
Magic wand number 1 is get rid of medical hub. Magic wand number 2, but that's it's easier said than done, because that's mostly the private sector activity. The government can get in on the bandwagon because it sounds like a successful story for Thailand that we can export medical services. Number 2, the government should seriously think about bringing in the middle classes who are spending money out of pocket into the medical care, into the public medical insurance system. Why should we be concerned about middle classes? After all, they are happily spending their own money. Why should the government bring in and pay it for them? Because I think if you have the middle classes paying their own money, it'll come back to haunt us later, that we will drive up the prices because paying for your own medical services, I'm sorry to say this in front of a bunch of doctors, but allow doctors to blackmail you into paying more for their services. So I want them to stop paying for their own service, get into a managed care system which will control cost a little bit better.
A round of applause for our 3 panelists, please. And let's move swiftly into the Q&A part, which I believe many of you have burning questions. So if you can please just stand up. Oh, it says time's over. Shall we have a Q&A? Let's have maybe 2 questions then. So anybody have 2 questions maybe, or 3? We have 3 panelists. So 3 questions, quick questions maybe. You could just stand and introduce yourself and ask your question.
ขออนุญาตถามเป็นภาษาไทยนะคะ มี2 คำถามนะคะต้องขอบคุณท่านอาจารย์ออกมาก่อนนะคะสงสัยแมจิกวันอาจารย์ได้สิทธิ์นั้นเดี๋ยวนี้เลยนะคะ อันที่1นะคะคำถามจะถาม Professor จากญี่ปุ่นนะคะว่าทำไมคนญี่ปุ่นถึงมีความคิดที่จะยินดีที่จะให้เพื่อนๆในประเทศญี่ปุ่นนะคะได้สิทธิ์ที่เท่าเทียมกันในขณะที่ เขาจ่าย contribution ไม่เท่ากันนะคะอันนี้คำถามที่หนึ่งนะคะคำถามที่สองขออนุญาตถาม professor จากจีนนะคะว่าทำไมหรือเป็นหลักคิดอะไรที่ทำให้เรามองว่าการจะทำให้คนไข้หรือทำให้ประชาชนจีนเนี่ยเข้าถึงบริการที่เท่าเทียมกันเนี่ยโดยใช้หลักคิดของ consolidate เพราะเมืองไทยของเราเนี่ยเราพูดกันถึงว่า consolidate เนี่ยมันแทบจะเป็นไปไม่ได้นะคะในขณะที่จีนเนี่ยมองว่าการจะเท่าถึงหรือ equitable healthcare health universal healthcare เนี่ยมันก็คือการ consolidate กองทุนต่างๆให้เข้าถึงกันนะคะแต่ในทั้งที่อย่างญี่ปุ่นเองเนี่ยมันมีแนวคิดที่ว่าต่างคนต่างคนละกองทุนนะคะในขณะที่เมืองจีนเนี่ยนะคะมองว่าน่าจะรวมกองทุนกันอะไรเป็นหลักคิดที่สำคัญที่มองว่าน่าจะเป็นประโยชน์สำหรับประเทศจีนในการเลือกที่จะ consolidate กองทุนค่ะ
Would you like to take the question first, Professor Ikegami?
Yes. Healthcare in Japan is regarded as a public good similar to education. In elementary schools, even in rural villages, the government has set up branch schools so that the children can commute to schools, where the school may only have 10 pupils, but the government is responsible for establishing the schools, paying 3 teachers to teach 10 children, because that is regarded as a human right. So that is the basis that if we regard healthcare as a human right, then accessibility issues must be solved, and it is paying according to your means, not according to your income. The second is that it is extremely difficult politically to deny services based on your income level. To say that if you can't pay for this new cancer drug, the nation can't pay for it, so the patient must pay for it. That becomes a very politically sensitive issue. So no government, even the United States government, has said that poor people should be only eligible for a subset of services. Even in the Medicaid, all drugs are on the list. So from an ethical and also a practical point of view, it's difficult to categorically deny services to the poor.
Thank you very much for the question. I think in China, for all these 3 health insurance schemes, they have the equal accessibility. So in other words, you can see the doctor in anywhere, but your financial responsibilities are very different. So this is very different from the Thailand. I just learned yesterday, say, you don't have the same accessibilities. You don't have the choices to see a doctor. But in China, you can see a doctor, but you have to pay on your own. And so that is very, very different. The second one is for the payment in China, the out-of-pocket is very, very high for some of the health schemes. But we think as like Dr. Naoki Akigimi just mentioned that the health is the right for the human being. So we have to be responsible, and the government should be responsible for those kind of health issues regardless of your income and your ability to pay. So that is the commitment. So this reason why we would like to consolidate all these schemes together. But as you know that for the financial responsibilities from the government, that is very difficult for them to move more money to the informal sectors and to the people without formal jobs, particularly for the current economic situations. As you know, in the last maybe 10 or 15 years, the GDP increasing growth rate is pretty high, more than 10%. But for the last maybe 1 or 2 years, it is only about 7%, or maybe this year maybe only less than 7%. So I don't think the government have enough money to provide the equal financial responsibility. That is the issue. And then, in order to solve that issue, we have to be creative. So one of the suggestions is, how about a possible strategy to combine the urban health insurance together? Because you have the employee-based health insurance and you have the resident-based health insurance, and they are in the same family, but in the same family, they were covered by the different health insurance schemes. So that is very difficult to deal with. If you, for example, we don't have the taxation system by the family members, so it's only by individual people. But in the future, if we have the taxation, like individual taxation, income taxation by the family members, that may be possible to merge these two schemes in the urban area together. Thank you very much.
So I think we've gotten two perspectives in terms of the ability to pay, which should be by their means and not their incomes. Are there any other questions? Maybe this should be the last question. There's one gentleman in the back. Can you please come to the front?
สวัสดีครับจะเรียนถามอาจารย์อำมานะครับเรื่องของพรข้อที่2ครับที่บอกว่าภาครัฐควรพิจารณาคนชนชั้นกลางผู้ที่จ่ายเงินเองเนี่ยให้เข้ามาสู่ในระบบประสิทธิภาพภาครัฐมากขึ้นเนี่ยเพื่อจะเป็นการคุมราคาของสถานพยาบาลได้เนี่ยคำถามครับว่าในเมื่อภาวะตลาดเนี่ยมันมีการแข่งขันกันเรื่องของการให้บริการกันมากนะครับทั้งแบบรัฐโดยเฉพาะโรงพยาบาลเอกชนเองเนี่ยโดยเฉพาะโรงพยาบาลเฉพาะทางด้านเดียวกับโรคนั้นหรือสาขานั้นเนี่ยนะครับคำถามครับว่าสิ่งที่จะมาพูดมาในพรข้อที่2เนี่ยมีความเป็นไปได้เพียงใดครับเพราะมองว่าคนผู้ป่วยเองต้องการการรับบริการที่ดีแล้วก็ได้รับความสบายคือลำพังไปโรงพยาบาลก็ทุกข์ใจอยู่แล้วขอบคุณครับ
ผมคิดว่าเขาเลือกที่จะไปโรงพยาบาลเอกชนหรือว่าจ่ายเงินเองและจ่ายเงินเองส่วนหนึ่งยอมรับว่าเป็นเพราะว่าทนการที่จะต้องรอหมอในภายใต้ระบบหลักประกันไม่ได้นะฮะอันนั้นจริงแต่ว่านอกเหนือจากนั้นแล้วการใช้เหตุผลในการเรื่องการแข่งขันว่าถ้ามีการแข่งขันแล้วราคามันจะ reasonable ราคามันจะเป็นไปตามใกล้กับต้นทุนนะฮะอะไรต่างๆเหล่านั้นผมคิดว่าผมไม่ค่อยเห็นด้วยเพราะว่าบริการที่เราไปหาหมอต่างๆนี่มันเป็นบริการที่มีเฉพาะหมอคนไข้ไม่ค่อยย้ายหมอเพราะฉะนั้นมันค่อนข้างจะเป็นมาร์เก็ตที่ไม่เพอร์เฟกต์มากๆนะฮะเมื่อมันเป็นอย่างนั้นแล้วการที่จะคาดว่าการแข่งขันจะทำให้ราคามันเหมาะสมโดยอัตโนมัติเหมือนกับกลไกตลาดนะคุณคงไม่ทราบคุณทราบว่าเปล่าว่าผมต่อสู้เรื่องจำนำข้าวมากมายผมเชียร์เรื่องตลาดเสรีอย่างเต็มที่เวลาพูดถึงเรื่องข้าวนะฮะแต่ถ้าเผื่อใครมาบอกว่าการรักษาพยาบาลควรจะเป็นตลาดเสรีผมก็จะสู้อย่างรุนแรงเท่าพอๆกันมันไม่ใช่เป็นสิ่งที่จะเป็นตลาดเสรีได้นะฮะอันนี้ผมยืนยันมีหลายอย่างที่เราไม่มีตลาดเสรีนะฮะเราแล้วบางทีเรามีตลาดเสรีได้แต่เราไม่ยอมให้มีเช่นหวยอย่างนี้นะฮะเรามีผู้ผลิตรายเดียวนะฮะแล้วผลิตไม่เพียงพอกับความต้องการเพราะเราจงใจให้คนบริโภคหวยน้อย เวลานี้รัฐบาลกำลังทำให้เสรีขึ้นเพื่อให้คนบริโภคหวยมากขึ้นต้องมานั่งตั้งคำถามว่าอันนั้นเหมาะถูกต้องกับจุดประสงค์ของรัฐบาลหรือเปล่าที่ให้คนบริโภคหวยมากๆมันดีสำหรับรัฐบาลนะผมไม่ปฏิเสธเวลานี้รัฐบาลคงจะได้รายได้จากกองสลากดีขึ้นเดิมออก60 กว่าล้านใบเดี๋ยวนี้เป็น100 กว่าล้านใบเพราะฉะนั้นการจะใช้กลไกตลาดเป็นข้ออ้างว่ากลไกตลาดดีเสมอผมคิดว่ามันดีบางแห่งมันดีบางเรื่องมันเลวบางเรื่อง
Thank you very much. I think for the organizer's sake, I should call the session to a close because I'm mindful of other sessions, although I would love to continue the discussion with our panelists here. Thank you very much, all the audience and all the smiling faces. I think our discussion has sparked some imaginative thinking in you, and so hopefully you can take what we've discussed, especially on the equity points, on the social dimension and the political points, forward into your 3 parallel sessions this afternoon. Thank you very much.
Thank you very much to the speakers and the moderator.